Hello, everyone. This is Dr. Mary Lauder, and you are listening to the Since You Put It That Way podcast. It's the show that examines various health, wellness, and medical topics from unique perspectives. We will be having discussions and guests that will cause you to pause and consider, well, since you put it that way. Welcome back, everybody, to another episode of Since You Put It That Way, and Megan continues to be our guest. And Megan, our physical therapist, who has joined my practice, Mary Lauder DO and Karen Medical, and Megan passed PT. There's just too many vowels in there to share, so we're just going to put them amongst ourselves, play Scrabble, and we're going to continue our conversation about fascia. We're going to look at some of the important questions, and I think it probably starts out this way. A physical therapist and osteopath went into a bar, right? Something like that, and I don't know what we did after that. Probably, I don't know, did we do stuff at the bar? Did we stretch it? Maybe, I don't know.
I don't know. Everyone came up to us, was like, my head hurts. My back hurts.
Exactly.
How do I fix this?
Exactly. I think we perhaps just ordered a round of something and then off we went, something like that. So, well, and as we get into this, continuing, there's some important facts about fascia that I thought were kind of fascinating. So, fascinating fascial facts. How's that for alliteration? One truth about fascia is that it's considered a newly discovered organ system that permeates the entire body. When I think of that, I think of the old football or basketball coach that always would say, drop and give me 5. When you didn't execute the drill correctly, you had to, you thought that you were strengthening yourself and everything was linear. You did a sit-up or you did a push-up or you ran in a straight line and ran back. That's not even, and fascia just doesn't even work that way.
No, I find it so fascinating. So a new organ.
Yes.
But yeah, it's been with us this whole time. We've just decided to recognize it as an organ finally.
Yes. So an organ would be what? A collection of tissues and cells with a primary function. That would be an anatomical definition. And it has 10, and also another fun and fascinating fact of fascia is that it has 10 times more proprioceptors than muscles. So proprioception for all of us is, where are we in space with our eyes closed? We know where we are in space with our eyes open because the optic tract takes it back to the brain and the brain figures it out. With our eyes closed, proprioception occurs what we say is in the joint, and it tells you where you are relative to being up, down, left, right, bent over, standing up straight. So it tells you where you are in relation to really to your center of gravity type thing. So 10 times more proprioceptors, which means the function and the sensory is in more fascia than it is the joint.
Yeah.
We always were driving things by where the joints said we were.
Yeah, I think that's interesting because that's what we were taught, but that's not how I practice.
Mm-hmm.
Because I always think about, okay, so then what is a muscle? Like, let's break this down. So myofascial.
Yeah.
Muscle fascial. So myo is muscle, but muscle is just the muscle cell. The contraction that happens within the cell. And then the fascia is what encases and creates the different fibers within that muscle organ. So
Right.
of course the proprioceptors are going to be embedded into the fascia.
Well, then the question I have is, fascia is supposed to be literally everywhere because it's in the internal structure and support for surrounding tissue. And we talked about last time it being really the primary thing that moves us from point A to point B. And it's in organs like appendix, it's in your organs like liver, it's in your organs like thyroid. So are there proprioceptors in those organs? And if they are, what are they doing?
I think they are. I mean, in my practice, I can feel the motility of an organ with my hands. And so Yeah, of course. I think there would be because let's think about this logically. If you eat something and it comes into your stomach through your esophagus, which has smooth muscle that helps bring it down,
Mhm.
and then it churns in your stomach, and all the acids and enzymes and everything break it down, and then it exits through a sphincter, which has to open and close. And then it goes out into your intestines, which have all these other smooth muscles that help push it down. Well, but then how does the bile get out of the gallbladder? How does
It's a
how does
chemical.
it's a
Chemical.
chemical,
Mhm.
but then just thinking about the movement of fluids through the body.
Well, it is also motion. It's probably chemical movement. So mechanical and changes in stomach acid content,
Mhm,
pH, amount of stomach acid, what's broken down, enzyme levels, things like that, which would come from the exocrine function of the pancreas as well as the stomach and part of the small intestine. But if a person has acute pancreatitis, we gut rest them, even water.
mhm,
If they have an acute gallbladder attack, we gut rest them, even
mhm,
water. Why? Because you have to digest water? No, all you
mhm,
do is assimilate that or absorb it, right? No, it's so that would be the mechanoreceptors that would stimulate and stretch. So that would be fascia as well.
mhm.
Yeah.
And so with fluid moving through the body, why wouldn't our proprioceptors be able to sense the change of pressure mechanically within our organs?
I think that they would.
Hmm.
So that would even then push to blood levels, blood pressure levels
Hmm.
in the blood vessels,
Yep.
lymphedema or swelling from lymph. Ah, all of a sudden, this is way more complex from drop and give me five or run in a straight line.
Or suicides.
Yeah, I remember. Oh my gosh, I remember those suicides. Shoot free throws. If you miss your free throws, you're doing a suicide. I remember those. Okay, let's do one more fun fact, and then we're going to go into some questions that we get from our patients typically. There are 4 different types of fascia: structural, intersectoral, visceral, and spinal, but they're all connected, which would make sense. So the structural would be more what we would think was the musculoskeletal, maybe a more linear. The intersectoral, I would think of that being diaphragmatic, whether it's a structural diaphragm like your respiratory diaphragm or a functional diaphragm across a joint or your thoracic area here. And then the visceral means guts, organs, and then the spine. That
Yeah,
makes sense. Yeah.
makes total sense to me.
All right. So fun and fascinating fascial fantastico fun facts. I'm can I say I'm out of the F words? I am known for the F word, so we will leave that one there and keep this PG rather than going to R. All right. All right. Here's a question. So I'm a patient. So why is it if my pelvis is tight, why do I get headaches?
It's such a fascinating question. And um, I'm actually really excited to also hear that from your perspective as an osteopath. Um, but ultimately, so speaking about different types of fascia, the spinal fascia,
Hmm?
and the Latin word for our dural tube, our dura mater, which is the fascia that surrounds our brain and spinal cord. It looks like a tadpole for those people who are like, what, huh? Um, Dura mater means tough mother in Latin. So, okay, so let's think about this. Like it is the thickest piece of fascia within our bodies.
Okay.
And it attaches at very specific places to our skeletal system.
Mhm.
The cerebral falx, I always say that word wrong.
Cerebri.
This, yes, cerebri, thank you.
Yep.
Through the center of the brain. So it's the piece of fascia that creates the two hemispheres of the brain.
Mhm,
On our sphenoid, right near the pituitary gland. So like back this way in the center of the head.
mhm,
The occiput, the
mhm,
base of our skull where our spinal cord exits.
mhm.
And then S2, which should be our sacrum. So the triangle bone that points downward on the back of your pelvis, and your tailbone's at the very tip. And so if you're having pain in your pelvis or your hip, or of course you're going to get headaches, because we're going to end up with tugs and pulls going all sorts, like all these different ways, and usually opposing. And the other interesting piece is all of our nerves exit this piece of fascia, and then that fascia then continues along the nerves.
Right.
And so then we can end up getting these rotations or torsions in my world, because our eyes will always try to keep us level. So if we
They
have
seek
these
the
bony,
horizontal. They seek the horizontal. Yes.
always, they're seeking the horizon.
Yep.
And so if we have a rotation or a torsion or an injury into a hip or pelvis, then it's going to create compensation injuries all the way up. And so, of course, you're going to end up with headaches. Or if you have a lot of headaches and you start getting relief with your headaches, and now all of a sudden you've got low back pelvic pain, well, okay, so now we're actually treating your whole body. We're unwinding you, essentially.
Yes. So, yes, I agree. And as an osteopath, what I would add would be that the Dura Mater, the Tough Mother, reminds me of Columbia sport clothes. Mother Boyle, right? She was a tough mother. But the Dura Mater attaches inside the skull. If you look at the skull as a bowl, multidimensional bowl. So you're right, the falx cerebri, which goes left to right hemisphere. Then you've got the tentorium cerebelli, which goes horizontal between the cerebral cortex and their cerebellum. And roughly it's in the mid portion of brain. And that then separates the top from the bottom. And so you literally, like if you have paper, you can literally get a kink. You can literally have things pull. And so and I think one of the most fun things to do with folks as an osteopath is treat them with craniosacral therapy, which when I had my interview for med school, I told the dean that I thought it was voodoo, but I'm open. And it's not voodoo. And it was fantastic to learn that. But the craniosacral, you're feeling the movement of the bones that are in the skull and that we learned in fourth grade were fused, but they're not fused. They have a beveled joint to them, and so they move back and forth. And then where the dura is attached, it also can put a strain pattern or a torsion on the paired bones. If they're not paired left to right, so that means you've got two of them, then they're one front and back. And that includes fine bones of the face, the bigger bones of the skull, and your frontal bone and back by the occiput. So those bones move in a very specific pattern. You learn the patterns of those. And then you can literally feel, because you can give a little push, and because it's considered a semi-open hydraulic system. What that means is if you have a boat, a rowboat, and you put it on the lake and you go to step in it and you're not really stable, the boat can scoot away on the water. If you put that boat on the concrete and you go to step in it, it ain't going nowhere. So that fluid there makes that boat move with just a little bit of a push. So when we do cranial sacral, and if anybody's ever had cranial sacral, it should be the gentlest of touch, the gentlest of feeling. And you're really feeling for not only what's happening there, but what it's reciprocating down the spine and other parts of the body. And as an osteopath, I can treat the base of the skull and release low back pain because I can hold the occiput, have it go through cycles of movement, bring it to what's called a still point, which is a therapeutic positioning, and then the sacrum relaxes. And I never touch their low back because it's fluid. And also, just as you were saying too, where the dura comes out each level of the spine and continues, that fascia is literally connected all the way out and back in. So you think of all these, spidey senses and things like that. Um, so, very often I would treat patients because patients would come in with headaches, CAT scan, MRIs were negative, no infection, no reason for that. Their eyes were tested, everything's good. And they go, we can't figure out why I have chronic headaches. I would ask them, did you ever fall on your backside? They're like, it's my head, doc. I go, I know, but did you ever, it's Michigan. Have you been sledding, as we call it? Have you been sliding? Have you been sliding down the hill and boom, 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 boom? Have you fallen on the ice? And oh yeah, last winter. Well, when did your headache start? Well, about 2 months later. Yeah, that would be right. So, and it wasn't, did you hit your head? No, I didn't hit my head, just hit my backside. So, and that would be, falling on your sits bones can jam the system all the way up. And so knowing the fluid mechanics, knowing how things work, knowing the movement of the bones, how the dura sits there, you literally can get a picture. And the cranial sacral system is so subtle in the fascial world that you can sit there and just hold the base of the cranium and think movements. And the body begins to release itself. And I remember I had a patient years ago, and the whole time I treated her, and she had chronic headaches, and I was treating no, she had chronic headaches and low back pain. I was just holding the base of her head, and I was talking to her about the farmer's market, and we were talking about all the great things. She goes, I pay for this, and I don't think you should be talking. I think you should be telling me what you're doing. I'm like, okay. So then I began to describe the movement, the motion of the bones and what I was feeling and the pulsations and where it was going. Now it's at this level, C5, C6, now it's down to T1, it's crossing the thoracic, and now we're going down to the respiratory diaphragm. Okay, now here the root of your mesentery is releasing, and she goes, okay, stop. She goes, apparently you're working. I go, I am working, but don't you think the farmer's market is much more fun to talk about? So
yeah, it's amazing what can be done without actually touching the area, like also with fascially as well. And I love what you said about there's so much intersection between craniosacral and osteopath and the type of manual work that I do, because it is that still point. We are looking for that still point. And because that's the space where the healing actually takes place.
yeah,
And where where the body and the nervous system can actually shift. And so I love that, in a world where we have to feel, it has to hurt, it has to be productive or uncomfortable. Healing, especially with our fascial system and especially with our nervous system and our craniosacral system, like thinking about our central nervous system, it can be subtle and it can heal without it being uncomfortable.
yeah. I think that's good to think that overall, to reframe
Mhm.
some of that. I was in conversation with someone recently about trauma, and they had a number of major traumas. And they said to go back to even consider any of those would be too painful. I said, what if there's a way to heal without having to go back and feel everything?
Mhm.
Because the trauma we know is hidden in the fascia, stored in the fascia. It's not hidden,
Mhm.
it's stored. Well, then you've got the idea of the subconscious relating to the fascia. And that can be in the amygdala, that can be in the basal ganglia and the cerebellum, actually, which is the lower area. And that area is where a lot of the unconscious body is driven from, the brainstem area.
Mhm.
So what if that connects to our biofield around us, where we maybe house our soul? I don't know. I know there's a biofield. Some people call it an aura. I tend to call it a biofield. And what if that's where the subconscious is as well? And then that's how we do all this connecting and go off into the woo-woo part of you and me be one there, sister. And we begin the kumbaya, right?
Right. I mean, in the many mystical traditions, the first body is our physical body, and the second body is our mental body.
Mhm.
And then the third body is our oh, it starts with an A. I'm forgetting a lot of words today. Goodness. But it's essentially
Astral?
um no, it's different, but it's essentially our emotional body.
Okay.
The astral body, I think, is number 6.
Okay.
But if we think about it that way, then yeah, like what if we don't have to relive our suffering?
I think I'm up for that.
Now, that doesn't mean we don't bypass what we've been through.
Right.
And I think this is where that tricky piece is like we can't bypass the pain. We can't bypass or ignore it. But
Right.
what if we just acknowledged it, loved it, and moved with it?
Hmm. And the body has, because the body has the inherent capacity to heal, and because what we've learned and seen the evolution of EMDR to tapping to thought field therapy to emotional freedom technique to my self-compassion and connection, and now trauma response and repair, a new program that I'm learning that treats the subconscious. What if it just, because we're building on the shoulders and the collective literally of the next, I mean, we're kind of like in this vortex of healing for the soul.
Hmm.
And there's this industry that wants to keep people traumatized because
Yep.
they can make money, and we can rub your tragus right here, which is that bump off your ear, and therefore you can treat your tragus, heal your vagus. you know and I'm like, seriously, it's not. If it were that simple, we would have figured that out a long time ago.
Hmm.
It's not just one nerve does a trauma make. It's
Hmm.
not only regulating the vagus. We've
Hmm.
got to do other things. It's not just the polyvagal theory as it relates to fascia.
It's
And
all of it. And we cannot forget about the soul.
right. And that would be the same thing. By focusing on polyvagal would be the same thing as drop and give me 5, run in a straight line, do a sit up and lift everything in a straight line. Then you get stronger because that's how your muscles function. It would be that same type of reasoning, linear healing, which is not at all how we got injured. We didn't get injured in a linear fashion either. Yeah. All right. Question number 2. Physical therapist and osteopath going. We went back into another bar, and then we got this question posed to us. This is kind of fun. I kind of like that little pretense there. So, hey, why does my right sacroiliac joint hurt when you're telling me it's my left sacroiliac joint that's tight?
Ah, I love this. I love this question. And this can go for almost any joint in the body. Um, People. So like, yes, we're picking the SIJ, the sacroiliac joint, because at least in the PT world, it is probably the least talked about joint, and it has so much implication, and it causes so much pain and dysfunction. And so, okay, so the right side is hurting, but I'm telling you the left side is tighter. Okay, let's think about this. Okay. If the left side is so tight that it's not moving, what do you think is moving?
The right side, it's more mobile.
It's more mobile. And so what has happened is that right side's either moving too much.
Mhm.
Actually, it is moving too much. And it's either moving beyond its threshold or too frequently within its threshold that's caused irritation. Like
Well,
I can make it that simple with a patient.
okay, so but where if the proprioceptors are in the fascia, you're having increased fascial strain on that side that's more lax.
Yep. And so there's going
Yeah,
to be more instability.
right. More instability and more pain through the fascial system because of the movement and just the strain. And then the chronicity sets up because the muscles then adapt. The fascia tightens a certain way. And then we literally, because it just takes on the, it shape shifts. Boom. And then you always get those pain patterns there. I mean, I think of everybody has tried to correct my right out turning foot my entire life. I promise you I was like that in the womb. I know I was, and I love it, and quit trying to fix it. you know, and do you know that your foot turns out? No, not aware of it. Of course I'm aware of it. My whole life, you know. And one of my grandmas walked that way. Say, it was just the funniest thing. She had the same turned out foot. Where'd it come from? I don't know, but I'm sure I sat that way in the womb. And then now, even now, stretching, and I know the patterns that are there, is when I'm more tight, that hip does not like internal rotation as much, and I have to spend more time really elongating that into, internal rotation.
And this is the piece we we as a society are just so stuck with perfectionism and symmetry.
Mhm.
And our bodies are not that. I mean, our liver, our biggest organ, takes up how much space on the right side of our body?
Mhm.
Like, it's just not possible. And then we have hand dominance, eye dominance, foot dominance. And it's not bad to have these imbalances. What becomes dysfunctional is when the imbalance is so big and we are not aware of it. So then we become a victim of our pain.
Okay.
And then that is then the piece of like, okay, so my right SI hurts all the time. It hurts to take a step. It's like jabbing. Okay, well, let's take a look at why you're moving that way. Let's take a look of what is causing that instability. Yes, your left SI is tight, but that may not be what's causing your instability because it's so much more multifactorial than that. It could be um, it could be a past trauma, whether that trauma is um, physical, emotional, or spiritual. And then, okay, we don't need to know necessarily what it is, but we do need to look at how do we train out of it to bring you back into function. And I generally will use symmetry as a guide, but that's not my ultimatum.
Right.
And I think as an osteopath, you're probably pretty similar
Yes.
because it's about finding the function and the ease and the flow in the body
Mhm.
to create the space to allow movement to occur that doesn't cause pain, because pain is what elicits the warning, warning, warning.
Yes.
And healing is not in that warning space.
Right. So let's go down from so the sacroiliac joint is where the triangle bone at the base comes together between the hip bones, sacroiliac joint. So then if we go down to the foot, let's go to plantar fasciitis. Let's pick on that. I love this because everybody wants to fix the foot. Now, your feet have multiple arches in it, that go across from your big toe to your small toe, from right, in front of your heel bone, left to right, so the side to side, and then downward. So we've got, transverse or cross arches and longitudinal arches. And it's really a work of beautiful architecture, our foot.
Mhm.
To get our different arches and structure of the foot to leave those really cool hang 10 feet on the concrete when you're wet. I love that, right? I did that as a kid. And I have flat feet, but I really don't. I have a shallow instep, which is a different than flat foot. And I had to wear arches in orthopedic looking shoes when I was a kid, and they hurt so bad because they pushed my arches up. They pushed my foot and made it rigid, and I could hardly walk. And I was told I had to get used to it, and I couldn't. And every year I would get really expensive orthopedic shoes that I just couldn't wear, and all I wanted was loafers and tennis shoes. And I never had foot pain. That was the funny thing. I didn't have foot pain. My older sibling did, and they had really deep arches. And they didn't have to use arch supports because they had deep arches. But because I didn't, or was perceived to not have arches, I was given arches that made them hurt. My feet hurt and I couldn't walk.
I'm going to work really hard to stay on topic here because feet and arches and kids and orthotics and all that stuff like sends me down a soapbox. So we will table that for another day.
But the point to fascia, when we look at orthopedics, when we look at plantar fasciitis, what's happening in the linear world is they're treating the foot. And you could end up, the foot be where things end up feeling, but you actually need to treat up the chain, up the leg, up into the low back, up into the diaphragm, up into the basic, the cranium. So can you address that?
Yeah, so Tom Myers with Anatomy Trains, he really did actually a lot of service, but also I will say a disservice to people who are looking for these constant solutions and these linear solutions. So there's the posterior longitudinal fascia, and what Tom Myers did is he's dissected multiple cadavers, and he's following the trains and the fiber lines through the fascia. And so the posterior longitudinal fascial chain runs from your toes, up the soles of your feet, up the back of your heel, through your Achilles tendon, into your gastroc, up into, I think, the medial hamstring. It crosses the SI, then it goes up the paraspinals, and then up into the occiput. So the paraspinals are those thick muscles that run up and along the spine. And so, yes, we do need to treat up the chain, but then I also take it the next step. So if that fascial chain is tight along the posterior line, what's happening on the front of the body? Why is the back so tight?
I think the back is tight because the front is not engaged. And it's not, I wonder if it's so much front to back, if it's not big versus little.
Ah, yeah. It's
Because the paraspinal muscles are thin. Think of like tenderloins, folks. That's our tenderloins. Plus our hip flexors are our tenderloins. But if we look at those spinal muscles like a tenderloin, they're long, they're linear, they go up and down. The broad muscles, like our gluteal muscles, are buttocks, as Forrest Gump would call it, right? And our hamstrings and our quadriceps are bigger muscles that are meant to hold us upright, but really it's our gluteal muscles. And those are most often inhibited in folks for a variety of reasons. And that's the muscles that tend to keep us up and walking, not the paraspinals. So I think because the gluteus muscles are inhibited, the front also shuts down, but then it just stiffens.
Yep. Yeah, and this gets into a really complicated conversation because there's actually two fascial lines through the front of the body, according to Tom Myers. And there's the deep anterior line and there's the more superficial anterior line. And so this is us thinking like super linear, drop and give me 10.
Right.
Because then there's also the functional lines, and the functional lines are your spirals. It's your glute max that
Okay.
then comes up into your lower obliques, which then crosses into your external obliques, which then crosses into your serratus anterior, which attaches into your scapula, and then crosses again across your rhomboids up into your other shoulder. And it's those functional lines that actually turn on our glutes. It's the rotational stuff. It's the side stuff. It's the ability to have the movement and, like you said, to stay out of the rigidity of it.
Yeah.
And when we are so front and back and we're so linear, then of course it's going to stiffen.
Yeah.
Because we need those small stabilizers active in all of our muscles. Even our spine has muscles that span 1 to 2 segments that actually decompresses our vertebra, and then it allows that rotation to occur.
Yes.
We have, everyone knows about the rotator cuff, or where I lived in rural Oregon, the rotor cuff.
Yep. Rotary cup.
Rotary cup is another one.
Yeah.
Our hips also have that same thing.
Yes.
And I would say in the majority of people, glute max is inhibited, but so are the hips,
Yes.
the hip stabilizers.
Yes.
And thinking about pelvic floor, then with hip stabilizers, the pelvic floor is just clenched. You
Yes.
know, 30 years ago, there's all this conversation about Kegels, contract, 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 contract. Well, now we are so tight. We are, dare I say, anal retentive. We are so uptight that we
Yes.
can't relax our pelvic floor, which then contributes to the rigidity. And I am finding actually really plays into what's happening along the back side of the body when it comes to fascia. So plantar fascia, yes, let's take a look. Like, let's have the conversation of, do you clench like you're trying to hold your poop in all the time?
No. Oh, that wasn't a question for me. No.
No.
Uh, but the answer is no.
But like these are the questions I will be asking, because it's not just what is happening at your feet.
Right.
That is just where your body is saying, help,
Yeah.
something's not working.
So, so pain then, kind of like anxiety, is really a messenger.
Yes.
And we've developed and lived in a system that tries to treat the pain by going to where the pain is to make that pain stop, which would be something like an arch support, an orthotic, an orthopedic shoe, whatever, something like that, to stabilize what we think is, but that is going to completely change the influence all the way up, not just what you're saying, the back chain, but those rotation chains that make the hips fire. So you literally could block the ability for the body's, you could block the body's ability to fire
Mhm.
by anchoring those feet, like in a set of, concrete shoes, as it were.
Yep.
And you literally might not be able to accomplish that which you're sent home to do by home exercises.
Yep.
Well, that's just a copay that's gone bad, isn't it?
And sorry to everyone who just blowing the mind of like, but it hurts. Well, we need to start looking at pain as not being bad.
Right.
There's different types of pain there, and we need to start creating a dialogue and a conversation about what the pain actually is and
Yes.
what that feels like. Is it truly acute injury, like injurious pain? Is it causing you injury? Or is it pain that is saying, you haven't been listening to the whispers, so now I'm going to hit you across the head with a 4x4 until you listen,
Okay.
or your feet.
Yeah. And what's interesting there is our whole concept of pain management that we've medicated causes further disconnect
Yeah.
by using the neural pathways in the brain and the mu receptors for morphine or hydrocodone or hydromorphone or things like that, that literally, or now the whole concept of either fentanyl or um, wait, what's the big one? Having a moment there too. Ketamine
Yeah.
that they're using for chronic pain, oral ketamine up to 9 to 12 years, and or IV ketamine. And the whole goal of that literally is dissociation. So the thing that we're doing in therapy is causing more disconnect from where we need to just stop and ask the question, what does this mean?
And what does this mean may be more than just physical.
Right,
Most of the time it is.
right.
And this is why having a great team and people that you refer to and your healthcare providers having a team and a referral source is so important, so that you're working as a team because we are in a system that does require us to specialize, which is a good thing. So then let's all work together with our specialties
Yes.
to heal.
And this is where folks like you and I literally don't fit in the system because of the fragmentation.
Mhm.
So we do a disservice to our community. We do a disservice to our public. And this is something that it does weigh on my heart a lot, that how our system is structured. And that the folks who think holistically, like yourself and myself, are the ones that get marginalized. We get pushed out. We get told we aren't doing enough work. We are told we're not billing right. We're not, fitting in. And I never fit into that system, even when I was a youngster in medicine. And even when I was learning medicine, I never fit into that because I just never thought that way. And so it's interesting that really now things may be catching up in our understanding that this is really the way to go. And that it is more complex but by complex, I mean interwoven. I mean,
Yeah,
holistic.
connected,
Yes.
that it's not linear,
No.
it's cyclical. And within in those cycles, there's going to be multiple cycles
Yes.
and, or more of a spiral instead of cyclical. Like within these spirals, there's going to be multiple spirals. Like I'm thinking fractals.
Yes.
And so with if we approach the body in that way in the practice, because I too have never fit in,
Hmm.
then all of a sudden healing can occur in ways that didn't seem possible before.
Yes.
And I just am so grateful to be working with another provider who gets this.
Yeah.
Like, what a service to the people that we get to work with.
Yes. It's much less lonely, and I don't hear crickets.
Yes. Or peepers.
Exactly. Exactly. So, all right. So let's go back to let's finish up with a couple more fascinating, fun fascial facts. And it dovetails into exactly what we just talked about. Fascia has a living intelligence. It's described with living intelligence that adapts and responds to support of the body's inner architecture. When one part of the fascial web is injured, the entire system responds.
Yes.
Yep.
It's been my experience in my career. Yes.
Yes. And then some have even described the fascia as part of or housing or being the soul of the body. I can neither confirm nor deny that because I don't have the tools to, but it seems kind of logical, kind of commonsensical, and yet no harm to believe that way. And it's actually maybe better to believe that way for outcomes by changing up perspective. So what we're really doing here by looking at fascia from a holistic perspective is we're really changing paradigms. And we're really reframing what pain may be, a messenger. Anxiety may be a messenger. I know that it is rather than a diagnosis. And it causes us then to see where we've been disconnected so then we can reconnect. In that reconnection to ourself, it's the safest place to be. From there, we can go anywhere because our fascia will get us there, right?
Yep. Yep. Our fascia is our mind, body, and spirit.
Yeah. So that's pretty, should we say, fascinating? I did just come up with that one.
Yeah, yeah. That was a good one, Mary.
All right. So on that note, the practices are, if you are in our community here, West Michigan, find us out, find the website, drmarylauder.com, make your appointments, get set up. Megan's got availability. I've got availability. We work as a team. and you can really get really good care for chronic issues, chronic pain issues. If you want to get off your pain medicines, I've got ways to help you doing that by doing pharmacogenomics and looking really at what medicines work and don't work for you that you've been prescribed. And as a physician, we can move all of that around. The key would be getting you off things that keep you dissociated and bring you back into your body. And the physical therapy would work to do this very same thing through hands-on and in all the modalities and multiple ways that Megan can help you. And we're located in downtown Holland, right above the JB&Me store. And we just moved spaces within that office. We now oversee the west side and have a window, which is a beautiful view now out of our office. And so it's a great place to get treatment and care. And I just invite everybody, and this is stuff to get your friends to listen to this. Get your friends, follow us on Instagram, Facebook. Just look at our names on Facebook and Instagram. Follow us. You'll be seeing great information. But this is important because between an osteopath and a physical therapist, when you can get us out of the bar and not taking questions there, you can actually get very good care and have a good time doing it from a really holistic perspective. And I think that's just super important. And so, take note of this and know that there is a way through what you're dealing with without being stuck in a linear system with answers and a bunch of stuff that just hasn't worked. There's actually, there's a reason that you're listening to our podcast today for sure, I would say. So we look forward to being of service to you in our region and area of the state. So thanks for listening to us, Dr. Megan Pass, Dr. Mary Louder, and Since You Put It That Way. And we hope you guys have a great day, and see you next time.
Thank you for joining us on the Since You Put It That Way podcast. Today's episode was written and produced by Crowded Table Productions. Technical editing, Malin Long Lopes. Sound editing, Jonathan Fiegel. Music, The River Jordan, written and performed by May Erlewine. Please rate and review our podcast as well. We appreciate your feedback, and hey, be positive, share the love.